Hello, I'm Dr. Tim Puckett, MD, board certified obstetrician gynecologist. I am with OBHG Hospitalist Group in Florida, and I want to share a life-saving story with you. This story actually begins, it takes course over 5 days, but on day 1, the patient presented to the OB emergency room and was seen by one of my colleagues with OBHG because we do take care of the ER and triage patients. The patient is a 27-year-old, gravida 1, at exactly 30 weeks and 0 days when she initially presented. She wasn't feeling well at home. She Googled some of her symptoms. She had a family member that is in the medical field and took her blood pressure, and her blood pressures were elevated. She called her primary doctor. They said, come into the OBED to be evaluated. Patient did not have any significant visual changes. She had some intermittent headaches, but did not have a headache at that time. She had an elevated blood pressure of 151/93, category 1 fetal heart tracing. PIH lab evaluation showed that her uric acid was elevated, and her spot urine showed 3+ protein. My colleague called the attending private physician, and they agreed to at least admit the patient for observation. Now, one of the most significant things in this patient's history, no prior surgical history, no other medical history, with the exception of allergic to latex and history of Wolff-Parkinson-White syndrome, which, as I'm sure you're aware, can cause cardiac conduction abnormalities and rapid heart rates and other cardiac problems. So the patient was admitted, and the care was assumed by her primary OB. Day 1 and day 2, she received betamethasone for fetal lung maturity. Day 1, she was seen by maternal fetal medicine. Day 3, she complained of epigastric pain and a severe headache. Now, with this patient and her elevated blood pressures, she is not a candidate for a beta blocker like labetalol that we usually use with preeclampsia or hypertension. And she's not a candidate for Procardia, which is a calcium channel blocker, because of her. So that just left us with hydralazine, and she received several doses of hydralazine through her hospital stay. On day 3, the maternal fetal medicine evaluated her because of her symptoms and deemed her to have preeclampsia with severe features. And she was started on magnesium sulfate for neuroprotection for the fetus, seizure precaution or protection for the mother, and induction was begun. Patient received Cervidil, 3 doses of Cytotec, beginning on the 3rd day into the 4th day. And then suddenly, on the 5th day, I got a phone call from the private OB that due to a family emergent situation, that person was not available and we needed to assume the care of this patient. So the good thing was I already knew about her. I knew about her we always really keep track of who's on labor and delivery, who may present a problem, trying to anticipate what kind of problems they may have. So suddenly I have this patient that is now 30 weeks and 5 days, steroid complete, receiving magnesium sulfate with severe headache, elevated blood pressures, and despite a Cervidil, 3 doses of Cytotec, and being started on Pitocin, her cervix was still only 1.5 centimeters dilated. So I met the patient, and I planted the seed that this didn't look like we were progressing rapid enough, and that we may need to expedite the delivery in the manner of a cesarean section. The heart tracing at that time was a little flat, but there were no decelerations. And part of it, I assumed, was due to the magnesium sulfate in the early gestational age. At that point, I left so that she could talk to her partner and they could come to grips of the current situation, and that hopefully we can move forward with a cesarean section. I stepped out of the room to get a cup of coffee. I got a phone call from the labor and delivery nurse saying, now we're starting to see some late decelerations. And I was able to pull up the fetal heart tracing on my phone, and indeed, there were some subtle but repetitive late decelerations. So that's when I made the decision we have to do the cesarean section now. So anyway, we had uneventful emergent cesarean section. Baby was delivered fine with APGAR 7 and 8 and did extremely well in the NICU. And it has really thrived, didn't really have any setbacks or problems or anything. Only required a little bit of CPAP, never had to be intubated. Baby is doing great. As a matter of fact, I checked on the baby yesterday and just amazing. So this is part of what OBHG does. This is what OB hospitalists do. We evaluate patients in the OBED, the emergency department of OB. We take care of them. If their provider can't take care of them, if the provider is out of town, if an emergency happens and the provider can't get there in time, or certainly for the people that don't have a provider, and particularly in Florida, we get a lot of people on vacation and suddenly something happens here, their provider's out of state, we're their provider then. So anyway, I was glad to be able to take care of this family and have a good outcome. And I think the important thing was to realize we can't always go with our standard protocols based upon patients' medical conditions may require that we deviate from that, because usually we use labetalol as usually our first choice, or procardia, and hydralazine is usually not our first choice, but we couldn't use those other two options. So anyway, that's my story of this wonderful outcome. Thank you.